Hello, students. Good morning. We are going to cover Chapter 11, which is pain assessment, and that is generally considered the fifth vital sign in our Jarvis book. We're going to look at what pain is, the function of nociception, and the patient's sensation of pain. We're going to differentiate different types of pain. We're going to look at acute versus chronic pain, describe the initial pain assessment that we would complete on a patient, and then compare pain assessment tools, and then look at the physical changes that occur because of poorly controlled pain in patients. So I'm sure you have had patients complain of pain. Patient reports pain to you, and at some point in time, you may or may not agree with what the patient said their pain was, depending on what the patient's face or maybe their physical attributes or maybe their actions were, such as maybe a patient telling you that their pain is 10 out of 10, but yet they have a smile on their face. So you may be thinking in your mind, well, it can't possibly be a 10 out of a 10. Maybe they didn't quite understand the scale, so you may have repeated it to the patient, and they may have repeated what their pain level is. Now, we sometimes mistake what we think should be the patient's pain, and then because of that fact, we under-medicate our patient. So if you don't learn anything from this lecture, be sure to remember that pain is really what the patient says that it is. Pain is what the patient states that it is. Okay, so it's subjective. They're going to tell us exactly what pain is. Normally, there's a stimulus that occurs. We have nociceptors or receptors along our body, in our fingers. They're generally all over in the skin, connective tissue, joints, in the abdomen, pelvic area. And when there's a stimulus, then it sets off an action generally that occurs. So that stimulus ends up going um, through the nerve fibers. We've got A fibers, which are more specific for sharp kind of pain because those fibers are myelinated. And then you have C fibers, which give you more of a diffuse pain. The patient can tell you, yeah, the pain is in my leg, but they can't really pinpoint exactly where. And that's because those C fibers are not myelinated, so the information is not very specific. And so the stimulus ends up going to the spinal cord, and from the spinal cord itself, then the stimulus is going to actually continue and go up. It's going to make some synapses or connections, and then it's going to go up to the thalamus and then eventually to the cerebral cortex. And this is where we perceive that we're actually having pain. Now, nociceptive pain have four specific phases, and those are transduction, transmission, perception, and then modulation. Now, in the transduction phase, what happens is because of that stimulus, once that stimulus occurs, such as someone stepped on a sharp nail, once that occurs, then we have a cascade of effects, something occurring. We have histamine being released from our nerve cells. We've got like prostaglandins. These are actually chemicals that are being released. And generally, then what happens is that transmission continues and then it goes to the spinal cord where it makes another connection or synapses at that point. And generally, at this point where the histamine and let's say prostaglandins, these are neurotransmitters, once those are released, again, it continues up to the spinal cord. From the spinal cord, actually, then what happens is transmission occurs. Now, in transmission, this is where we have a connection made, or there's a synapse, or there's a cleft that the message have to actually jump across and continue upwards. Now, at this area, we have opioid receptors. So Opioid receptors are effective, say, if a patient is in pain and we administer pain medication to the patient, this is where it would actually work. So the opioid receptors will actually bind to when that transmission occurs, and then it would prevent the patient from actually experiencing pain. So those opioid exogenous medication would actually work during this point of transmission. So it would generally just block the pain signal from going forward. Now, not every signal is going to be blocked. Some signal possibly will continue to go through on up and eventually reach the cerebral cortex. So if this signal continues through the hypothalamus, then we have the third phase, which is perception. Now, in perception, patient is then made aware that there is something that is causing that pain to occur. So then what we get is we get a reaction, right? If you stepped on a nail and you're perceiving that you've stepped on a nail, what is going to occur? You're probably going to say, ow, or something to the effect, right? Or scream because you've now perceived the pain occurring. So we have kind of an emotional response to the pain. We're sensing that something is wrong. And then the final phase would be modulation. So once our brain perceives it, then something is going to happen at that point. Our body is again going to, so that signal is coming back down from the cerebral cortex. So our body is going to try to mitigate that pain. So it's going to modulate the pain. Again, we have some neurotransmitters or chemicals that are released during this time period, such as we hear about GABA, which is in say medications that you can find over the counter, like multivitamins, etc. We also have serotonin and norepinephrine. Those chemicals are released that will actually help us take care of the pain and for the person not to feel the pain as much. So it sort of modulate that pain. We don't feel that excruciating pain that we did. An example would be maybe a woman giving birth. Now she experienced the pain, but then the body actually modulates that pain. And that is the reason why maybe women have more than one child, because if that pain was as intense and as acute and she continued to feel that ongoing pain, then I'm sure she wouldn't engage in the act that would cause her to have another child going through the same pain. So the body helps to modulate that pain so we don't feel the pain as much. Also, if we give the patient medication, this is also where opioid receptors would go into effect again. So opioid medication would work at this point as well. Now, pain is very protective for us. It means that something has occurred. So it keeps us from our skin or our cells from getting further injury because we are experiencing that pain. Now, with neuropathic pain, there's an abnormal processing that is occurring. Now, this kind of pain is not like the nociceptive pain. So there's something abnormal going on with this. An example would be if a patient has phantom pain. You've heard of phantom pain, where a patient's extremity is removed, but yet that patient continues to feel pain in that extremity that is no longer there. Or maybe a patient that has diabetes. They complain that, they have pain in their lower extremities. Or how about with herpes? Shingles? I don't know if any one of you have ever experienced shingles pain, but that can be a very debilitating pain for patients to experience. Um, for neuropathic pain, we cannot really see the pain. We have to go by what the patient says the pain is. We can't necessarily do an MRI and say, oh, okay, there is where the pain is occurring abnormally. That cannot be seen. We just have to go by what the patient states that the pain is. But again, it is pain that does not follow the typical pathway, okay? And it's a little bit more difficult to treat. Where does pain come from? Well, there are different types of pain. We have pain such as cutaneous pain. Now, if you've ever gotten like a paper cut and you feel that kind of burning pain, sharp pain, really hurts, we call that cutaneous pain. There's also visceral pain. This is pain from the deep organs, such as if you've ever had like your gallbladder act up, right? The kind of pain that the patient experienced. Or maybe if you've ever had a kidney stone, that kind of pain would be a deep visceral organ. A stomach ache, your intestines are aching or hurting. So visceral pain are for the deep viscera, the organs that are really inside the body. Um, and then we have other examples would be appendicitis if you've had appendicitis, or maybe the patient has had a pain with an ulcer, like a stomach ulcer pain, gastric ulcer. Those are the types of visceral pain. Now, deep somatic pain would be pain that's in the muscles or the tendons. If you've ever had any of those injury and feeling those pain, that's deep somatic pain, pain in the joints itself. So ask an arthritic person what that pain feels like. That would be considered deep somatic pain. And then referred pain, this is pain that is elsewhere other than where it originates. So maybe a patient is having, say, an MI, so pain in their chest, but they're not only having pain in their chest, the pain can also be referred down the arm. So they'll be complaining of pain down the arm. And why do we have referred pain? Because that body part is innervated by the same nerve that actually innervates the original area. So that's why the pain is considered a referred pain. This is a slide related to referred pain. So if we take a look at the picture on the right and look over her left shoulder where you see it says pancreatitis, patients with pancreatitis have the pain referred up to the shoulder, okay? And then cholecystitis is pain that's referred to the right upper back area. So I really like this slide because generally when patients are complaining of pain in those areas, it doesn't necessarily mean it's what's located in that area, but the pain referred from someplace else to that area. The liver is referred to the right shoulder. Can you imagine that? Where exactly is the liver? The liver is in the right upper quadrant of the abdomen, right? But yet it's referred to the right shoulder. And that's simply because it's been innervated by the same nerve that innervates the liver. With pain, we can classify pain as acute pain versus chronic pain. If it occurs for greater than, say, 6 months, we consider that chronic pain. If it occurs for less than 6 months, then we consider it acute pain. So if a patient had ended up with a motor vehicle accident and, say, fracture the arm or the leg, then that is acute pain. A patient just have surgery, so post-op patient having acute pain. Chronic pain is something a little bit that lasts a little bit longer, such as maybe the person have cancer, bone pain, and that's just ongoing. So that would be considered chronic pain. Breakthrough pain is also another term that we utilize. And this say would be given for a patient who we have given medication to cover, and the patient experiences the pain before the next time the medication is due. So that pain level spikes just before the medication itself wears off completely. We consider that breakthrough pain. Now, to assess pain, we have to do frequent assessment of the patient's pain. And again, pain is what the patient states that it is. Now, for the older adult, do you think that they experience pain like anyone else? Absolutely. So they experience pain just the same. Even though they're getting older, it doesn't necessarily mean that they have less pain or they're less sensitive to pain. Now, the older adult may not want to tell you that they're having pain because, for the most part, they don't want to bother you with their discomfort. So they'll actually bear the pain and experience that pain without saying a word. Now, if they were having acute pain and it's not managed appropriately, this would then turn into chronic pain. And we know that if acute pain turns into chronic pain, it is much harder to treat. So we never want that to happen for a patient. That is why it is so important that when a patient has pain, we treat the patient for the pain that they state that they have. And we don't treat them because of what we think or how we think they should be treated, but we treat them for the pain that they currently have. So, do you think that older adult, as they age, experience pain? Do you think that that's a normal phenomenon in aging? Is that pain? No, it is not. Not because our age is increasing mean that we should experience pain. Again, pain is a symptom of something occurring. So the older patient is having a problem when they experience pain. Okay? There are plenty of older people that you probably know that they live their life without any kind of pain, right? Probably better than you and I sometimes. They can do these activities without the aches or the discomfort. But again, there's a process going on while the patient experiences pain. Um, Older adults are also afraid of becoming addicted to narcotics. So they may not tell you that they're having pain, or they say no because they don't want to take those meds and become addicted. Once a patient is taking the pain medication for the pain, there's generally no way for that person to become addicted. The reason that addiction comes in is when the patient starts taking the pain medication for reasons other than pain control. Now, do you think people with Alzheimer's experience pain? How about infants? Do you think infants experience pain? They both do. Now, the Alzheimer's person may not be able to tell you that my pain is 10 out of a 10, but you can see some actions possibly that that person is exhibiting that means that they're having some discomfort, right? So that person starts wandering, getting up, and really they're appearing a little bit agitated, they're moving rather quickly. Or the infant is crying and cannot be consoled. They can't really tell you, hey, I'm having back pain or my leg hurts, but they can cry. And the type of cry that they have can signify that something is wrong. I don't know how many of you have been around an infant, but you learn to perceive, like a mom learned to perceive the different level of cry. There's a quiet cry, I'm a little irritable right now. Maybe I want to be held, or the cry that's because I am hungry or I'm wet, right? Or the cry that, someone come, and give me some attention right now. So that kind of piercing, colicky kind of cry, right? That infants have. So you learn to recognize the types of cry that would allow you to offer different types of comfort or treatment to that infant. Are there gender differences when it comes to having pain? Who experiences pain the most, men or women? I'll give you a moment to think about it. Did you decide? Well, if you said men, your answer may not be as correct. If you say woman, well, you may have it there. I'd give you that. Although, within our society, men are raised to really not express their pain, right? So it's not that they're not feeling pain, but they're taught to be stoic about it. So they can't really show a lot of emotion, even though the thing may hurt like crazy. Yeah, they're taught to, be stiff-lipped about the pain. Women, on the other hand, are taught to show their emotions, right? So when women experiences pain, then the friends need to know, everybody need to know sort of about how much pain the person is having. Now, it can be a little bit different culturally, right? Because some cultures, you cannot really express pain in public, like our Western culture. Someone's having pain, then you'll make the person aware. But there's some cultures that if a person is having pain, they state, I'm having pain, and yes, it hurts a little bit here, etc. Then there are other cultures that um, the expression would be everyone in the world need to know. So they'd be screaming, "Wah!" So the world knows that they're having pain. And then there are other individuals that would throw the covers over their head and they're in a fetal position. So you may think the person is asleep, but unfortunately, they're not asleep. They're in a lot of pain and discomfort. So we need to know how that individual expresses pain, and then if there are any cultural differences related to how they express pain as well. Also, we have to look at how pain is managed. This is very important. How do we manage the pain, right? Again, what is pain? Pain is what the patient says that pain is. So it's always subjective. The person that experiences the pain is more reliable, right? They're the ones experiencing the pain, so they should be able to tell us what the pain is all about. The unpleasant sensory experience that they're having. I've had the unfortunate opportunity to witness a nurse, I guess, getting relief from her position because she didn't believe what the patient was telling her when the patient was stating that she was in pain. So the patient notified the nurse that they were having pain. The nurse medicated the patient appropriately the first time with the appropriate medication, and shortly after, the patient called again and stated that they were having excruciating pain and that um, they're still in a lot of pain. Whatever was given did not touch them because they're still having a lot of pain. So the nurse, I guess, just got annoyed and didn't believe it and thought the patient was quote unquote drug seeking. And so the nurse determined that she was going to bring medication in for the patient, which she told the patient she would. But the nurse returned, administered what she said was medication to the patient, and um, then, of course, left. Told the patient the medication would work and left. Patient again put the light on. This time was really in agony and crying. And I think at this point, I, as a nurse educator, was walking by. I believe went into the room, saw the patient, had the patient's complaint, and then I went to see if I could medicate the patient or notify the physician. Saw that the patient was medicated once. The patient said, I just got medicated. The nurse didn't sign off any medication on the patient, so I asked the question, well, patient said they were medicated a moment ago. Where's that admission uh, um, in the chart for that medication? So the nurse said, I actually didn't give the patient any medication. The patient said that you gave the medicine. So she admitted that she actually gave the patient a saline flush instead of a narcotic. And of course, that's a no no. You don't ever want to do that to a patient, right? And so instead of notifying the physician and having the physician maybe write another order to cover the patient, she had the patient assume that they had gotten medication. Now, it's not a good thing. So this nurse was relieved of her position. We always want to be sure that we treat a patient's acute pain. Otherwise, this acute pain is going to become chronic pain. And then, of course, it's going to be much more difficult to treat. Now, just to say a word here of caution, even if a patient came to the facility seeking medication or drugs, quote unquote, it is not our responsibility to try to get the patient out of that drug seeking mode. Our one nursing shift will not be able to do that. Generally, they don't come to the hospital because they want a detox, right? So even if they were taking medication and they had a drug problem, their body has now become tolerant to that medication, which means if they're having a problem, this is acute on top of a chronic problem. So we cannot expect the same medication that they've always been taking to work for them. We have to give them additional medication in order to cover the acute pain that is now over the chronic discomfort that they've always felt. I know in our society we do have an opioid problem, right? Heroin overdose is an issue, as well as methadone, which we give to treat patients, has now been over abused as well. So we know that there is a particular problem out there, but every time a patient comes and seeks assistance, we have to actually um, do what we can for our patient. There are different tools that we can utilize with pain management. One of those tools would be the FACES pain scale, where the patient can look at the face, and if it's a crying face, they can give us that information. They don't necessarily have to tell us a number. Or we can use it with a number, 0 to 10. 0 is the face that is smiling and happy, no experiencing of pain, and the 10 face would be one that is crying and is just in a contorted in a lot of pain and discomfort. There's also an assessment tool initially when our patients are seeing that if they're having pain and discomfort, we have to document exactly where that is. And that is captured on the right side. With pain, there's some parameters that we look at for pain, such as the intensity of the pain, how much pain the patient is having, the quality of the pain, where the patient tells you exactly what that pain feels like, burning pain, throbbing pain, etc. The onset and duration of the pain, so when did it begin, how long does it last, what relieves that pain, so what makes it better or what makes it worse, um, and then does it affect the patient's activities. So that information we need to know as well when we're assessing a patient's pain. So when we're doing assessment objectively, of course, the first thing we're going to do is assess. So assess, assess, palpate, percuss, and auscultate. Those are the techniques that we actually utilize. So in assessment, we're going to use our eyes. We're going to look at where the patient complains of pain. So something like a joint. If there is pain in that joint, well, maybe we can see edema in that area. Okay, we can maybe see redness at the joint, or if we palpate it, maybe we can feel that area. Maybe with movement, that area has crepitus in it. That's the bone on bone, rubbing on bone. Or maybe we can feel a heat in that area, right? Because there's some edema in that area. And maybe if we move that area a little bit, we find that there is limited range of motion in that area. Okay, so that's how we can look and assess if there's any pain within a person's joint. In their muscles, again, we can look at the skin color. What does it look like? Does it look red and inflamed? Or maybe is it cyanotic? Okay, so we're looking for those things. Is there edema or a mass in that area? And then, of course, you're going to palpate and see, does the patient wince when you touch the area? So they're complaining of pain in that area. That would give us a sense as to if that patient is having some discomfort in that area as well. So a patient can experience pain without actually saying a word. So remember that Alzheimer's patient I was asking about? Sometimes they can't tell you that they're having pain, but there's some things that we can see that would actually give us a sense. So we have some acute pain behaviors, and it's not only Alzheimer's patients you'll see this in, but you'll see it in other patients as well. A patient may be guarding that area. Let's just say the patient came in and they have right lower quadrant pain, right? And when you go to start palpating the area, they actually quickly throw up their hands to prevent you from actually touching that area. So this would be called guarding the area, right? They don't want you to press, because once you press, it's going to cause a lot of discomfort. So they're guarding the area. Or maybe you start palpating, if you look at their face, and it's becoming contorted, they're grimacing. Or you may hear the patient moaning. Have you ever been in a nursing home and you just walk along and you hear something that sounds like, mm, mm, right? So the patient is moaning because they're experiencing some pain. Or maybe it's that patient that is now agitated, right? They won't keep still. The arms are flailing. They won't stop moving. Now you have to try to use a board to keep that IV straight in the arm, or they keep getting up and getting out of bed. They're like agitated. Or your patient is restless, right? Maybe it's a patient who is diaphoretic, they start sweating. Okay, you check the patient's vital signs, and the patient has some vital signs. Now, one thing about vital signs is once that pain becomes acute, you will not see changes in a patient's vital sign. So, if they're complaining of acute pain, sometimes we hear nurses saying, "Oh, the patient's blood pressure is still low and their heart rate is normal, so they're not experiencing pain, right?" Well, those changes don't occur except in the acute phase where the body is actually trying to compensate for that experience. So the blood pressure would become elevated, the heart rate would become elevated. But once the body learns to accept that pain, sort of it learns to live with that pain, then equilibrium occurs, and so you will not see those changes at all. Chronic pain behaviors, this is for the person that has chronic pain. What you may see is the person is not as active as they were before, so diminished activity, or you may hear the person sign all the time. So you're sitting, and then the person is just, you may hear another sigh, right? So these are more subtle signs that you'll see or hear the person, or you may just see them rubbing the area, right? So they're rubbing over that joint or wherever the discomfort is, or they may be bracing it. Maybe it's an arm that is hurting or a shoulder that is hurting, and they just have the arm bent. They're just holding on to that arm. Or maybe the pain is so chronic that it's preventing them from eating, and they don't have any appetite anymore. So these are some subtle things. It would affect their sleep, and they can't sleep very well, etc. These are things that we look for, so we know if the patient is having chronic pain. This is a CRY scale that we utilize with, well, it's supposed to be with post-op pain for patient. Generally a younger patient this is utilized with. So the patient may be crying, and then again, depending on the type of cry. So if it's a high-pitched cry, they generally put that as a 1. It's on a 2 scale. And if the pain is unconsolable, there's no way that you can comfort this child, right, with everything that you're doing, then that would be a 2 on this CRY scale. And then you can see the changes in vital signs. You would give it a 2 if it's greater than 20% of the preoperative value. So you have to do some trending and look at what the pre-values are before. So we can use this one on infants. So once again, pain is not a normal part of aging. Really, an older person should not be having pain as a normal part of getting old. Although when we get a little bit older, there are some chronic disorders that we could have, right? The patient may have arthritis or osteoarthritis, could have had cancer diagnosis. Maybe they have constipation. If you've ever experienced pain from constipation, you know what that feels like. Or maybe they've had an MI, or they have heart problems and they occasionally have angina, that kind of pain as well. So we may think because the patient have those that they're supposed to have pain as they age, but remember, pain is a symptom of something else. Okay. And again, they may refuse pain because they don't want to become dependent on the pain medication. So they refuse those pain medication. Again, with dementia, some of the things that we can look for in a patient is look at how they're breathing. Are they hyperventilating? Remember, sometimes to get rid of pain, sometimes patients will be breathing, right? So breathing a little bit more quickly, deeply, and faster would cause the patient to sort of hyperventilate as they're trying to relieve the discomfort that they're feeling. Okay, so you may see the patient groaning or moaning or crying as well. Facial grimacing you may see, and your patient, could be pulling away from you when you're trying to do something with the patient. So just be aware that you could see these actions from patients when they're having discomfort. And then in documenting pain, with our patient, we're going to document what the patient states. So subjectively, what that information tells us. Patient says, I've been having pain for a few weeks. It's epigastric pain and it occurs within a half an hour of eating greasy or fatty food. And then they describe the pain. It's stabbing, it's squeezing, it radiates, right? And then the patient tells you, well, my pain is 10 out of a 10 scale. Also, I have some nausea with it, right? So those are accompanying symptoms. The patient may tell you, well, at home, this is what I take. So I take antacid at home, but it doesn't give me a whole lot of relief, right? And then the patient may say, well, the pain goes away after I bring my knee to my chest and I don't move for about an hour or so. And then objectively, you would write what you see or hear or feel, etc. So here, the patient is diaphoretic, patient is grimacing, having difficulty concentrating, breathless during the history, arms guarding upper abdominal area, the abdomen is distended, severe tenderness noted in the left upper quadrant, and epigastric palpation. Bowel sounds hyperactive in all four quadrants. So this is where your head-to-toe assessment has been done, and these are your findings. Okay. Now let's look at a question. A patient is crying and says, please get me something to relieve this pain. What should the nurse do next? Verify that the patient has an order for pain medication and administer order as directed. Or assess the level of pain, ask patient what usually works for his or her pain, administer pain medication as needed, then reassess pain level. Or assess the level of pain and give medication according to pain level and then reassess pain. Or reposition the patient, then reassess the pain after intervention. What is your response? Our answer is number 2. You assess the pain, you ask the patient what usually works for their pain, then you can administer the med, and then, of course, after medication, which is your intervention, you will be doing an evaluation. So you are going to reassess the patient's pain level. You don't want to go in with a narcotic when the patient says, oh yeah, it's just a headache and I usually take Tylenol, right? Yeah, we don't want to do that. Any questions? We can pick up the questions in our Zoom session. Please be sure to write them down if you have additional questions.